personalized guidance, as well as we give you notes on the topics. So you can use the code Dr. Divya 20 for subscription for discount on the subscription plans. Also, you can book a slot for personalized counseling session where the details will be explained to you, and you will have a good mentorship. So this internal exam marathon classes, we have started since April 22nd. So it's about a duration of 45 days. So here we offer you rapid revision of all the important questions, then a quick revision of all the volatile facts, as well as multiple choice questions will be covered. So all this will assure you top-notch grades in the exam. And this is beneficial for everyone, all the students from different universities of different states. So you can use the code Dr. Divya 20 for the first free live class. So with this, we'll begin with today's marathon series of Thorax. So today's objectives are, we have, we'll be studying, mainly the topic is lung. So dealing with lung, we have pleura, pleural recesses, fissures of lung, hilum of lung, bronchial tree, and bronchopulmonary segments. So all of these are very important questions. Most MCQs, short answers, long essays are asked based on these topics. And even in practicals also, discussion is based on these topics. So first we'll begin with short answers. So first thing is the pleura. So pleura, here we ask basically the layers of the pleura, as well as the reflection of the pleura is asked as a 3-mark question. Pleural recesses are asked. So we'll go one by one. So what do we mean by pleura? So pleura is a serous. So we have to answer the question as in the following: the definition, the layers, the reflection, pleural recesses. This more in detail I will again say later. Then applied aspects of it. So when we say the pleura, so the pleura is a serous membrane. Okay, so the definition we have to write: pleura is a serous membrane which is lined by flattened epithelium, that is called as the mesothelium. So on each side, this pleural cavity will invest the lung and it will line the thoracic. So it will invest the lung, means it covers the lung as well as the thoracic cavity. So epithelium lining this membrane, so will secrete a thin watery fluid, okay, serous fluid, which is called, that is the serous fluid. It is a lubricant there so as to prevent the friction. So the layers here, we have 2 layers. If you see, we have the visceral layer and the parietal layer. So the pleura has got 2 layers, visceral and parietal. So the visceral layer invests the lungs. Okay, it covers the lungs. It is adherent to the lungs. It cannot be separated from the lung, except near the hilum and along the pulmonary ligament area. We don't see it, but other than that, it is investing the lung in all the surfaces of the lung. Whereas the parietal pleura, see, as the name says parietal, visceral means viscera, so it covers the viscera. Whereas the parietal layer is basically which lines the, parietal means outside, so it lines the thoracic cavity here. So this parietal pleura, now if you see, this is how the pleura is formed. So when during the development, the lung bud will invaginate into the pleural sac here. So this forms, when it invaginates, it covers like this. So this becomes the cavity, that is the pleural cavity. This becomes the visceral pleura, and this outside one becomes the parietal pleura. So this parietal pleura now, so basically the more emphasis is placed on the parietal pleura. Here we have 4, pleura here, we subdivide into 4 areas. One is the cervical pleura, we have the costal pleura, the mediastinal pleura, and the diaphragmatic pleura. So 4 parts are there. Okay, so they are the subdivisions. So basically it is subdivided according to what surface of the thoracic cavity and the in what other structures it is related to. Okay, so in that way, we name it as cervical, costal, mediastinal, and diaphragmatic pleura. So the costal pleura, now if you see, this is the costal pleura. It lines the inner surface of the thoracic wall. Okay, that is thoracic wall. When we say the ribs, the costal cartilage, and the as well as the intercostal spaces, it will be covering here. Okay, so this is loosely attached to the endothoracic fascia. Okay, and in the living, we can separate them. Then we have the diaphragmatic pleura. Diaphragmatic pleura is covering the inferior surface of the, it is in relation to the inferior surface of the lung. So it will be covering the superior surface of the diaphragm. Okay, covers the superior surface of the diaphragm. So here what happens is when we are in regular, like now when I'm speaking, I'm breathing also. So that is known as the quiet breathing. Okay, not very conscious breathing. It's a quiet breathing. So during quiet breathing, the costal and the diaphragmatic pleura, okay, these two pleura, that is the costal pleura here and the diaphragmatic pleura, they are in opposition to each other, okay, below the inferior border of the lung. This is the inferior border. So here what happens, these two pleura comes in opposition. Then we have the mediastinal pleura. So the mediastinal pleura, as the name says, it lines the corresponding surface of the mediastinum. Okay, yeah, this mediastinum is the central portion, no? Central space. So it covers the corresponding, means the right side covers the right side and the left side covers right side and the left side covers the left side. So here it will reflect along the, that is the lung, okay? It reflects along the root of the lung and becomes continuous. So if you see here, near the root of the lung, it is reflecting here. This will be the root of the lung. So reflects here and it becomes continuous with the visceral pleura, okay? Next, we have the cervical pleura here. The cervical pleura, it is a dome-shaped pleura. So it extends into the root of the neck. This is the root of the neck here. So it extends into the root of the neck for about 2.5 centimeters, okay, above the medial end of the clavicle. So when we see here, this is how we mark, okay. So 2.5 centimeters above the medial third of the clavicle. Up to here, it extends up, okay. And 5 centimeters above the first costal cartilage. This is the first costal cartilage. It will be about 5 centimeters from here. So this so this one, you know, the cervical pleura is also called as the cupola. Okay, it is called as cupola and covers the apex of the lung. Okay, so this portion, it covers the apex of the lung. So here, usually when we, why this is important is because when we are doing a intrathoracic needle, like for aspiration or anything, if you have to put a needle in that area, we need to be very careful. Okay, if the above that, it will be covered by a suprapleural membrane. Okay, so these are the things which you should know. So the reflection of the pleura here, if you see, it will be same on either side, that is the cervical pleura. So you mark a point about 2.5 centimeter above the medial third of the clavicle. Okay, the next point you will mark about the sternoclavicular joint here. Okay, then you mark the midpoint of the clavicle. Sorry, the sternum. Okay, so near the sternal angle. Okay, you mark the midpoint of the sternal angle. So you join all these things here. So this is the cervical pleura here. When you join this point, okay, the middle third of the clavicle as well as 2.5 centimeters above that, when you mark a point, and at the sternal, that is the sternoclavicular joint, when you mark a point, what you get will be the cervical pleura. So from this point, you mark here, then you mark the midpoint of the sternal angle. So this and below, that is the mediastinal pleura, will differ on the left side and the right side. So on the left side, you mark on the sternum at the level of the fourth costal cartilage, and next you mark on the sixth costal cartilage. So when you draw a line, you have to form a C-shaped curve here, okay, with the concavity towards medially, and this gives you the mediastinal pleura of the left side, because here we have the cardiac notch. Okay, so that is why we have this. It is this way. Okay. Whereas here we just mark the sternal angle, midpoint of the sternal angle, and the next point will be at the xiphisternal joint. Okay, so that will give you the mediastinal pleura on the right side. Then for the diaphragmatic pleura, so from this point, that is sixth costal cartilage, we mark in the mid-clavicular line. Okay, so mid-clavicular line, we mark a point on the 8th rib, and 10th rib we mark in the mid-axillary line. Okay, so this gives the diaphragmatic pleura. And on the right side, the same thing, midpoint of the ziphisternal joint. Then you mark midpoint, that is 8th rib in the mid-clavicular and 10th rib in the mid-axillary line. Okay, so that will give the diaphragmatic pleura. Okay, so the same thing continues behind also. So we mark this point, that is the 12th rib, okay, on the lateral border of the. So in this diagram, you can mark. In the cadaver, we usually turn it and then mark, okay. So 12th rib at the lateral border of the erector spinae muscle, and you mark 2 centimeters away from the midline at the level of T12. So this whole thing gives you the diaphragmatic pleura. So these are the things which you should write. So when we write about the pleura, okay, so what we need to keep in mind is, so what do we mean by pleura? Okay, the definition, okay, and what it contains, the content of it, that is the serous fluid, and why we have it is because it prevents the friction. Then the layers, the 2 layers, okay, that is visceral and the parietal layer. And in the parietal layer, we have 4, that is the cervical, then we have the mediastinal, then we have the costal and the diaphragmatic, okay. So these you will, what it is, briefly you have to write about it, okay. And applied aspect, last will be the applied aspect, okay. So applied aspect, I will tell you for pleural rhesus, the same thing you will write here also, okay. Right, so these are the things. So this is how we summarize. So pleural rhesus, I told you, I will say it again. So that is why I didn't mention it there. Okay. So when we say pleural recesses, so normally, no, there is a small space between the parietal pleura and the visceral pleura. Okay, that is a potential space, which is filled with a thin layer of serous fluid. Okay, but in certain areas, okay, of this pleural reflection, which we saw earlier, okay, that is where it reflects onto the diaphragm as well as the, so where it reflects near the diaphragm and in the mediastinal region here, what happens is there is a very wide space, okay. There is a wide space between the visceral, means between the pleura which is covering the lung and the parietal pleura which is lining the cavity there, okay. So the boundaries of the thoracic cavity, what it lines, right? So there is a wide space. So this expanded space between the visceral pleura and the parietal pleura, we call it as the pleural recess. Okay, so that is the definition of the pleural recess. So we have 2 pleural recesses mainly. Okay, that is which one? The costodiaphragmatic recess and the costomediastinal recess. Okay, costodiaphragmatic and the costomediastinal recess. In addition to this, there are very small recesses. Okay, one is the right and left retroesophageal recess. Okay, because esophagus, it occupies the posterior mediastinum, superior mediastinum, as well as the posterior mediastinum it occupies, right? So there, behind that esophagus, there is a small space. Okay, on the right side and the left side, that is known as the retroesophageal space. Okay. Then there is a small space here where the heart rests on the diaphragm, that is known as the infracardiac recess. Okay. So those are very small spaces, but mainly we have the costomediastinal and the costodiaphragmatic recess. So here now, what will you write is, so first we have to know the boundaries of it. Okay, so costodiaphragmatic recess, so it is located inferiorly. Okay, it is located inferiorly between the costal, okay, here the costal and the diaphragmatic pleura, between the costal and the diaphragmatic pleura. Okay, so vertically it measures about 5 centimeters and lies opposite to the 8th to 10th rib. Okay, lies opposite to 8th to 10th rib. Okay, you can see it here clearly. So it is the space between the costal and the diaphragmatic. So this is the diaphragmatic, this side would be the costal. So this is the space, okay, extending from 8th to 10th rib, okay, along the mid-axillary line. So this is what you are written. So what is the importance of that? What is the applied aspect here? Is this is the most dependent part, okay. So any collection, pleural effusion, when there is a pleural effusion, the first place to collect will be this pleural recess, that is the costodiaphragmatic recess. Okay. Then we have the costomediastinal recess here. So costomediastinal recess is located anteriorly, that is between the costal, and the costal will be covering the sternum, inner aspect of the sternum, and the mediastinal pleura between the sternum and the costal cartilages. Okay, so here between the sternum and the costal cartilages, that will be the mediastinal pleura. Okay. So usually if it is obliterated, no, so when you move, when you are looking for when you do a percussion, like when you tap your finger and look for the sounds, you will see that in that area, right? As you move, because of the cardiac dullness there, you will move from a resonant note to a dull note. Okay. So that is the thing. So here, when the fluid collects in these spaces, we call it as the pleural effusion. So this is one thing you need to write there. So that is about the pleural recess. Okay. So pleural recesses when we say, so what do you mean by that? Okay. So you have to write. Okay. So pleural recesses, what do we mean by that? That is the expanded spaces, okay, between the costal and the the parietal and the visceral pleura, no? That is the thing. Okay, so they are the expanded spaces. Okay. So that the expanded regions. Okay. So why they are helpful? What is the function of this pleural? Why do we have it in the first place? So it allows for the expansion of the lung, especially during deep inspiration. Okay. So it allows for the, so it serves as a reserve space. Sorry. It serves as a, it serves as a reserve space for the lung to expand. Okay. For the lung to expand. So that is especially during deep inspiration. So that is why we have those spaces. Okay. So that is the importance of that. After that, you will write the types of okay, the location or the type of pleural spaces. That is the costodiaphragmatic, and there is other one is the costomediastinal. Okay, costomediastinal. So basically, as the name says, between the costal and the diaphragmatic pleura, costal and the mediastinal pleura. Then we have other two small, that is the right and left retroesophageal. Okay, esophageal. And we have one more is the infracardiac. Okay, infracardiac. So these things you should know. And the applied aspect. Applied aspect is about pleural effusion, you will write. Okay, so applied aspect, you will mention about pleural effusion. Okay, so these are the things. Then coming to fissures of the lung. Okay, so fissures of the lung. So where it is, what are the two types of fissures and what is its importance? Why do we have the fissures in the first place? Okay, so see, the lung could have been a single structure, but there are fissures. Why it has fissures? So if you see the thoracic cavity, it is like a conical cavity, right? It is not like a box. So when the lung has to expand in all the directions and you need to have the full extent of lung expansion, what happens is, so the lung moves because of the shape of the thoracic cavity, it moves in different directions. So if you feel the respiration, when you feel how the lung expands, so in the apical part, it expands upwards, whereas in the anterior, that is upper anterior part, right, there you have kind of, it expands laterally, forwards and laterally. When you take a deep inspiration, you can feel it. Okay, whereas in the lower part, it will expand, okay, laterally and backwards. So to allow for that expansion of the lung in all the directions, no, we have the fissures. So that is the importance of fissures. Okay, so we have two fissures. One is the horizontal fissure, which we see mainly in the right lung, okay, but not necessarily always. So sometimes as a variation, we may not see the horizontal fissure, okay. But generally, if you see, it is only on the right side. And an oblique fissure on both the sides, okay, the right and left sides. So I told you the importance of it. So where is the extent of it? So when we draw, okay, so when we start the oblique, so we put the point at this level, that is at the level of T3, okay, in the, what is that, midline posteriorly, okay. So we mark a point at T3, so it begins from there. Then we put a point on in the mid-axillary line at the level of fifth rib, okay, and then in the front at the sixth costochondral junction, okay. So this oblique fissure extends all the way like that to the front. So this is the marking or the of the this thing horizontal, sorry, the oblique fissure of the lung, okay. So those are the things which you need to write, okay. So fissures, so why they are present or the importance of it, okay, and the types. So we have two kinds, that is horizontal. Horizontal is only on right side, okay, and we have other one is the oblique. Oblique is important because it is present both the sides, and it allows for the expansion of the lung, okay, present on both sides. Okay, then you write about this extent of this one. So from where to where it is present, okay, and write the importance. So these are the things which you need to write in fissures, okay. Then coming to hilum of the lung. So hilum means the point where the structures enter or leave the lung, okay, that is known as the hilum of the lung, okay. So what are the structures at the hilum of the lung? Okay, so basically they are the structures which are entering the lung and which are coming out from the lung, okay. So you should know on the right side and the left side, what are the structures entering and leaving the lung. So mainly the structures which enters and leave the lung here, okay, we have from anterior to posterior when we go, okay, anterior to posterior. You can say it both the ways, anterior to posterior or superior to inferior, okay. But this is easier to say, remember, anterior to posterior, okay. So VAB, okay, VAB, that is vein, artery and bronchus. So we have pulmonary veins are paired veins. So we have superior and inferior pulmonary veins, one pulmonary artery and bronchus. In right side, we see two bronchus, epartial and hypartial bronchus, okay. So this is what we see. So why here, one thing you should keep in mind is veins we show here in red color, okay, whereas artery we show in blue color, which is other way around in all the other parts of our body, right? Here mainly because this pulmonary artery is coming from the pulmonary trunk, which is coming from the, which is draining the blood actually from the, which one? Bringing blood from the right ventricle, where it is deoxygenated, okay? So deoxygenated blood is brought to the lungs by this right pulmonary artery, right and left pulmonary arteries. So that is why it is shown in blue. Whereas these pulmonary veins, they take the oxygenated blood and they open up in the left atrium, which where the oxygenated blood comes. So that is why it's shown in red, okay? Right, so anterior to posterior, we see this. On the right side, okay, there is bronchial arteries, okay? Here we see superior and inferior pulmonary veins. We see the pulmonary artery, and most posteriorly, we will see the only one bronchus, left principal bronchus. Here we are seeing two bronchus on the right side because the right principal bronchus, okay, after the trachea bifurcates into two, okay, what happens is on the right side, so that is the principal bronchus where it bifurcates, okay. That bronchus, that is the primary bronchus, it divides into secondary bronchus. So secondary bronchus are lobar bronchus going to each lobe. So here what happens is in the lung, right side, Usually what happens, principal bronchus enters the lung and then divides. But here, in this case, what happens is it divides before it enters the lung on the right side. That is why we see two, this thing. What is that? Bronchus here. Okay, you should remember that. So these are the things which you will mention. Okay, so it is surrounded here. It is surrounded by the visceral pleura here. Okay, and where the visceral and the parietal pleura will reflect here. Okay, so you will see like these two layers. Below there is a dead space which is known as the pulmonary ligament, and this pulmonary ligament contains dead space which allows for the expansion of the pulmonary veins during increased venous return. Okay, in addition to this, there are bronchial arteries, bronchial veins, as well as lymphatics, okay, and nerve plexus. So these are the things you should write. Okay, so the definition, the structures of the hilum, difference. Okay, so you can actually, first you will write what do you mean by hilum of the lung. Okay, where it is present. Okay, the location is, it is present on the mediastinal surface of the lung. Okay, it is present in the mediastinal surface of lung. Okay. Third thing you will write will be mediastinal surface of lung, right? After that, what are you going to write? You will write the differences. So first, what you will write for the right lung and for the left lung. Okay. What are the differences you will see? Okay. So draw the diagram and mention the structures from anterior to posterior, the arrangement you can remember. Okay. And list out these structures present. Next short thing on bronchopulmonary tree. So you need to know the bronchopulmonary tree before you understand the bronchopulmonary segments. Okay, so what structures form the tree? What are its divisions and the structural differences and clinical importance? Okay, so here these are, so when you see here, what are we seeing here? We see the trachea. So trachea is a continuation of the larynx, right? Larynx continues as the trachea. So trachea divides into the principal bronchus. So we have the right principal bronchus and the left principal bronchus, okay, or the primary bronchus. Primary divides into secondary bronchus, which are otherwise called as lobar bronchus, okay, and lobar bronchus divides into the third, that is the tertiary bronchus, which are known as the segmental bronchus. It means each bronchus goes to each segment of the lung. So that is what it is. Okay. So, so when we see the further structure here, okay, the structure differs, external structure. So in histology, you will study more about the structural differences there. But here you have to know a few things. Okay, so one is this bronchopulmonary tree, we divide into two areas. Okay, so one we say as the conducting system, and one we say as the respiratory part. Okay, so conducting part and the respiratory part. So which is the conducting part here? So from the trachea up to the terminal bronchial level, it is known as the conducting part. Okay, so trachea, the main bronchus, segmental bronchus. Okay, then the bronchioles up to terminal bronchiole becomes the conducting part. Means here there is no respiration taking place, means there is no exchange of gases there, but only air is traveling there. Okay, it forms a passage for the air. From this terminal bronchiole up to the alveoli, okay, up to the respiratory bronchiole and the alveoli, this we call it as the respiratory part. Means from this onwards itself, okay, that is from the respiratory bronchiole onwards itself, the air exchange happens. Okay, so that is the two parts. So the structural differences also happen. So in the trachea, you see a cartilaginous ring here, which is a C-shaped cartilage, because posteriorly it is absent to allow for the expansion of esophagus, which is situated posteriorly. So the same structure continues up to the principal bronchus. But as we go to the secondary and the tertiary, as we go, this cartilage is not present as a circle there, like, C-shaped. Instead, it is placed in broken plates. Okay. So that is mainly because there the cartilage is basically present there as broken plates to just provide the firmness for the structure. That's it. Okay. So that it doesn't collapse completely, because it is mainly conducting the air. It is not exchanging the air. It is only conducting the air. Okay. So not so as to not to prevent its collapse, it is present that way. But as we come down, okay, towards from the bronchus, when it changes to bronchiole, we don't see the cartilage. Instead, we see the smooth muscles more there, okay, all the while. And by the time we come to the alveoli, we just see a single layer of squamous cells, okay. So why the difference is, in bronchioles, what happens here, from this terminal bronchiole level onwards, what happens is respiratory part, it is exchanged. So here, there is what happens, the structures, whatever was passing through these structure will diffuse from one side to other, okay. So here nothing should, any foreign substance shouldn't diffuse or shouldn't cross each other, right? So for that purpose, if any, the allergen enters, okay, if any foreign body enters, allergen enters, this bronchioles in the bronchioles, no, immediately go into a spasm. Okay, so when it has to go into a spasm, it should have smooth muscles which will contract immediately so as to not to allow those substances to pass. That is why in allergic asthma and all those things, no, they feel breathless when they are exposed to any allergens. Okay, so that is the bronchial tree. Understand? So these are the things which you need to write. What are the structural differences? Okay, so structures forming, the division, structural differences. So applied anatomy, I told you already. So that is the thing which you need to write. Okay, so coming to the short essay now. So this is bronchopulmonary segment. Okay, so what do we mean by bronchopulmonary segment? So definition, structure, contents, its special characteristic features, segments in the right and left lung, and clinical importance. You will explain the answer. Okay, so what is the definition now? Definition is, the bronchopulmonary segments are well-defined, wedge-shaped sectors of the lung, okay, which are aerated by a tertiary bronchus or bronchi, okay, bronchus, the tertiary bronchus, okay, so it will be aerated, means each segment will have one tertiary bronchi, okay, so that is the definition. So it's a well-defined wedge-shaped structure or a part of the lung where it is aerated by a pulmonary single, okay, tertiary bronchi. So what are its characteristic features? So one is, it is a subdivision of the lobe of the lung, okay, so it forms a part of the lobe of the lung. So we have two lobes on the left side, three lobes on the right side, right? So lobes are further subdivided into segments. So they are the subdivisions of the thing. Okay, so of the lobe. Then it is pyramidal in shape. Okay, so each of these structures here, it is pyramidal in shape with the base directed towards the surface of the lung, and the apex of this apex will be directed towards the hilum of the lung. Okay, and it is surrounded by connective tissue. Connective tissue is present, and it is aerated by a segmental bronchus. So if you see here, there is a tertiary bronchus, which is otherwise called as the segmental bronchus. So it is aerated by a segmental bronchus. Okay, and each segment will have its own artery and vein. They are the bronchial arteries. They are not pulmonary arteries. Okay, remember that. It will have its own artery and vein, that is bronchial artery and bronchial vein. Whereas the pulmonary veins, okay, here again, remember why it is shown in red. Okay, I already told you. Segment. Okay, that is one more thing. And each of these segments has its own area of, this is lymphatic drainage and autonomic nerve supply. Okay, and important, so clinically, is each of these segment can be resected or removed independently. Okay, each can be removed. So that is the importance there. So how many bronchopulmonary segments are there on each side? So there are about 10 bronchopulmonary segments on each side. Okay, so on the right side and the left side. So on the right side, we have the superior lobe. Superior lobe will have an apical, an anterior and a posterior bronchopulmonary segment. Middle lobe will have lateral and medial, and inferior lobe will have superior, anterior basal, medial basal. Okay, medial basal will be towards the medial surface here. Okay, medial basal, anterior basal, and we have the, so anterior basal, this is the anterior basal, lateral basal, and this is the posterior basal. Okay, so these are the segments here on the right side. On the left side, when we see, okay, so you can see here, this is apical. I'll repeat again, apical here. This is the anterior. Here you can see the posterior. Okay, then we have in the middle lobe. Middle lobe we have, this is the lateral and this is medial. Okay, and inferior lobe, if you see, will have anterior basal. Okay, so anterior basal, then the medial basal. Medial basal you can see here, this green thing. Okay, medial basal, and then lateral basal. Okay, and you will have a posterior basal. So these are the, here you can see. Okay, lateral basal, and this is the posterior basal. Anterior basal, this is the lateral basal and posterior basal. On the inner surface, there is the medial basal. On the left side, here we will see apical, anterior and posterior, as in right also. And here, instead of middle lobe, we have the lingular partner. So here we have the superior lingual and inferior lingual. So this whole thing forms a part of the upper lobe. In the lower lobe, we have same thing, anterior basal. Okay, anterior basal, the anterior basal, the lateral basal, posterior basal, and on the inner surface, there is medial basal. Okay, so these are the bronchopulmonary segments. Now, what is its clinical importance? When you write about clinical importance, here you have to remember that tuberculosis and bronchitis and non-malignant, that is benign neoplasms, they are restricted only to one segment. Okay, so they do not spread to other segments. Only in very advanced thing it can, but usually they will be restricted to each segment. So we can resect in the initial thing, we can resect the segments. Okay, so now which segments are affected commonly? So any segment can be affected, but some segments are commonly affected, like in tuberculosis, the apical portion is commonly affected. Now, why apical only? Because here what happens is, apical part, the oxygenation is less. So even though we have our lungs, subconsciously, I mean, without conscious effort, we are not using the full capacity of the lung. Okay, we are hardly using any part of the lung. Very little we are using the lung when we are respiring. Okay, so because of that, what happens is, some portions of the lung will have very less aeration. Okay, very less aeration. So this anaerobic bacteria, like tuberculous bacteria, it will thrive in that atmosphere where there is less oxygenation. So the apical portion here will have less oxygenation, and so we can see the tuberculous lesion was beginning there. Then next thing is abscesses. Okay, abscesses basically big secondary due to a foreign body or an allergen. We see abscesses. So usually abscesses are more common on the right side because the principal bronchus is more straight there and short. Okay, the right bronchus. So that is why any foreign body will go straight into the right before going to the left. Okay, so more likely to go to the right than the left. And here, abscess will be more common in the dependent part. So the this portion, okay, that is the superior part. Okay, superior part of the that is the inferior lobe. Okay, superior segment of the inferior lobe, as well as the posterior segment of the what is that upper lobe. Okay, they are all dependent parts. So when we lie in a supine position, those parts are in contact with the floor or the flat surface where we lie on, right, on the bed. So those are dependent part where it can get collected, form an abscess. And malignancy is more common in the anterior segments. Okay, anterior segments, because anterior segments are more close to the hilum where there are lymph nodes. Okay, and usually lymphatics and all those things are the channels for the spread of malignancy. That is why we see it there. Okay, So this is the thing. From here, it can spread to anything, but usually commonly we see in those segments. So that is what you will write. Okay. So bronchopulmonaries, to summarize now. So it is a very important question asked in almost very alternate papers. So you need to know it very well. Okay. And even in dissection, when you explain about lung, they ask you about bronchopulmonary segments. So first you will write definition that it is a wedge-shaped, okay, well-defined wedge-shaped structure, or you can also say pyramidal, okay, of a sector of the lung, okay, so a sector of each lobe of the lung, and then it is aerated by a tertiary bronchus. So this much you write for definition. You will write the characteristic features which I mentioned. Okay. And after that, you will write about its structure. Okay. So you will draw a diagram here and write the structure. Okay. So you will show, like showing the alveoli here, then you will show the artery and vein and all those things, and intersegmental vein you will show. Okay. So draw the structure. Then after that, you will write about the segments, how many segments are present on each side, okay, the right and the left. And finally, you write about the applied aspects, which I mentioned, okay. So those are the things which you need to write about. So always give the headings and write the answers. So that gives a good presentation for the answers, okay. So with this, we complete today's class. So thanks for watching. So you can download the app and access and make the best use of the app. Okay, so on Google Play or App Store, you can download. And for more content, you can follow the social media handles also. That is at Facebook, Instagram, and we have Telegram as well as the YouTube channels. Okay, so thank you. Have a nice day. Until next time, bye for now.